start with a quick case. 3-year-old boy with severe developmental motor delay with achondroplasia. He had no head control and he was unable to sit independently. So that is extremely delayed, even for achondroplasia, where you normally expect them to walk by about 2 years. And so normal cognitive development, though, and normal CT by report in infancy, neurological exams, so severe weakness and upper motor neuron signs. So what's the diagnosis? What's wrong with this kid? What does he have wrong with him? So he has foramen magnum stenosis, the first thing you have to rule out in achondroplasia. And this boy had it decompressed. He has some neurological dysfunction subsequently, but he's up and able to walk and has made remarkable improvement. So, foramen magnum compression, 60% of these kids have it. It is very common in achondroplasia, but only achondroplasia, and it can cause all these things. It occurs because, as you've heard from Ben, there is abnormal endochondral ossification. Right? There's a downregulation of endochondral ossification. And so we know that the foramen magnum is formed by bones, some of which are formed by endochondral and some intramembranous. So it results in narrowing, as you see in the achon skull compared to the normal. So really, if you're in a highly specialized unit, we don't always MRI every single child, but I think if you are not extremely experienced in achondroplasia, it is probably a good idea to image every child early in life. We're using sleep study and other techniques to monitor the secondary effects of the compression. But I think it would be best to just image the foramen magnum. Natural history is slow relief of the compression with growth over the first few years, so minor tightness can be tolerated. Surgical decompression, about 5% of the kids need it. Fusion is not required if you do an occipital craniectomy and a C1 decompression. It is not required. There are significant complications, neurological injuries, CSF flow abnormalities, hydrocephalus. This is not simple surgery. One of the things that we've learned in achondroplasia, although we know that instability is not common in achondroplasia, minor instability, physiological instability in the upper cervical spine in face of a very, very tight foramen magnum can result in neurological injury. So you have to be very, very careful with this. So here's an example of a child with diastrophic dysplasia with significant C1-2 instability. Look at the relationship of C1, C2, and here. And this girl had obviously moderate instability. And on the MRI, you can see she has cord compression. So we stabilized her. We didn't have to decompress her because in extension, the cord had lots of room around it. Obviously, if there was significant stenosis, even when the neck was in extension, then you would have to decompress and fuse at the same time. So instability, when do we see it? In basically every single dysplasia other than achondroplasia. Etiology is variable. Ligamentous laxity, odontoid hypoplasia, very common. Os odontoideum is actually much, much more common than is previously thought. And there is often associated stenosis. And you can see, when you're measuring this on a plain x-ray, the indirect evaluation using the Atlanto-Dens interval, I don't think is very useful. I measure the space available for the cord. To me, that's important. And once you get under about 13, you better be thinking about imaging the cord and making sure the cord compression is not occurring. The evaluation is just being a good doctor, doing a careful history and physical exam. When you have a hypotonic baby that has delayed motor milestones, figure out why. Has there been a functional loss? The child with Morchio or SED that is walking well up until 3 or 4 and then starts to have worsening endurance and inability to walk the same distance they did a year ago. That's very important. If they develop urgency, bladder urgency, where they didn't have it before, very, very important finding. And document those neurological findings. If you don't document them, you can't look back and see, oh boy, clonus, it's a new sign. Very, very important. So how do I evaluate them? I do flexion, extension, lateral cervical spine x-rays. The problem is many of these kids have very poor ossification in the upper cervical spine. And in that circumstance, I go directly to a flexion extension MRI. We do them under sedation, and we've written an article to show that it's a very safe thing to do. I use CT primarily for operative planning. So here's an example of flexion extension in a child with pseudoachondroplasia. And the red bar is space available for the spinal cord. So that's a real problem, isn't it? Here's an example of the flexion extension MRI that I just did recently. And it shows an extension. The cord is not being compressed, but there is some signal change in that cord. And look what happens in flexion. Significant cord compression and significant myomalacia. That needs to be managed. It will continue to get worse. Remember, some of these kids can have occiput C1 instability as well. Look for it. So when you're planning management, make sure that you run these kids by a pediatrician who feels comfortable with the medical problems that occur in these children. Make sure that you're well prepared preoperatively with anesthesia. You don't want to be dealing with an anesthesiologist that can't intubate your child with an unstable, stiff cervical spine and the child dies. And guess what? That happens. That happens in this country. We have multiple examples of it. Make sure that you have a team that is comfortable managing these kids. Make sure that you've got the appropriate equipment available. If you need an extra small halo and all you've got is a large sitting there and your pins and 2 inches from the skull, you're in a real problem. If you don't have a brace that's going to fit, if you don't have instrumentation that's going to fit in that 2-year-old spine, you've got a problem. So make sure you consider it all preoperatively. And make sure you have good support from physicians who can help you manage these children preoperatively, intraoperatively, and postoperatively. Just a typical spine procedure, but there are a lot of loose parts here. And if you don't have it already, it's a problem. So C1-2 fixation, if you can achieve it, transarticular fixation is excellent fixation, I think. But the problem is that many of these kids, the anatomy doesn't allow it. And here you see where the trajectory of the screw is going to go right through that vertebral artery there. And I would suggest you don't do that. I've done that before, and it is extremely frightening, and you can kill your patients. When you run into these variations, there's other ways to achieve stability in the older child. And here I used a transarticular screw on one side, C1 lateral mass, and a C2 pedicle screw on the other. And so there's lots of variations and lots of techniques that we can use. In many of the young children, it's difficult to achieve stability at C1-2. And sometimes you have to go to the skull. And this is a very simple way that we wrote up recently using cables and a draft from the posterior pelvis. Remember in cervical kyphosis that many people who are not comfortable with skeletal dysplasias react to this immediately with a surgical plan. We know that in many forms of skeletal dysplasia, and dystrophic dysplasia being the classic, this improves spontaneously. And it'll improve spontaneously in over 75% of these kids. And so you can watch it. Now, you obviously want to make sure there's no issues with cord compression. You might want to do further imaging. but you can watch many of these children safely. Late instability under a successful fusion is actually more common than most people think. We wrote an article at JPGS just recently, 30% incidence of instability under a stable, successful fusion in Morchio and SEDC. So you can extend that fusion, and occasionally even subtle instability, which you can see right here compared to this side, results in significant cord compression, and decompression and instrumentation is required in these children. So, important take-home points. The diagnosis is important. If you know the diagnosis, you know what to expect and you know the natural history. Do flex extect cervical spine x-rays on all your children with dysplasia. Get a flexion extension MRI if there's any concern about imaging or neurological findings. And have appropriately sized instrumentation and immobilization available if you're going to operate on these children, and expect instability under a successful fusion in the long term. Thank you very much. We can maybe answer a very quick question.
At what age do you do your flexion extension for the first time, and do you repeat it and when?
I've done flexion extensions in a 3-month-old child with SEDC. I can't see anything on the plain X-rays. The ossification is so poor, and the child was so hypertonic. I didn't want to risk the possibility of cord compression. So you can do it very, very early.
And you repeat it when?
It depends on the diagnosis. So if I did it on that child with 3-monthers, the cord was fine, but I repeated it about 6 or 8 months later, actually I think 8 months later, a little bit more narrowing, and about a year later, significant compression. So you can see progression here. So I think it depends on the diagnosis. For the average child with skeletal dysplasia, where I have good imaging which shows that the space available to the cord is satisfactory, I may never do it. Where a child with Morchio, I would probably repeat it every year because of the MPS deposition resulting in stenosis, which is not visible in plain X-rays. Does that answer?